Okay, this is a new chapter in Pharmacotherapeutics 3 and the neuropsychiatric disorder. So today we will talk about sleep disorders. Okay. So everyone, we know that sleep is a very important part of our life. You can see that even one day if you does not sleep well, the whole we have to take another 4 or 5 days to get out of the hangout that causes without sleeps. Okay, and it's a very important even physiologically for a human body, because the cells and tissues which is continuously working for 24 hours, sleep gives some kind of relief to them, rest to the body. Okay, so the whole body get regenerated. So it's a time for regeneration, so that the day begins with fresh thoughts and will be active. But many of them now this disorders is quite frequently seen in many people. It's my voice is clear.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
So there are again same like anxiety disorders. There are many components involved here in the sleep disorder. We talk about insomnia, hypersomnia, and many other factors or different terminologies are involved here. So it's collectively known as the sleep disorders. And lot of same like anxiety disorder, neurobiological systems models are involved here, hormones are involved here, and for the reason for sleep disorder is again even pathologically there could be some reason, physiologically and also behaviorally. It's how the person behaves based on is also the sleep disorders usually seen. And this is what the overview of the chapter, give little bit of introduction. Again, neurobiology, same like anxiety, we see like what all the neurological system that involved in sleep and wakefulness. And also there are different stages of sleeps. Okay, so called as rapid eye movement and non-rapid eye movement. So based on the stages, the sleep, the extent of sleep, the quality of sleep is usually measured. And also there is assessment. So there are a lot of scales are involved here, how the sleep goes on, and to make a person classify as having sleep disorders, these assessment scales are very helpful. And also classification of sleep disorder, and also common sleep disorders and management, and there are few references are involved here. So you can see that the sleep, um, the word itself is a very nice word where we call it as regularly recurring, right? So sleep is not just once or twice sleep is done, and this it's a recurring event, and also very rapidly reversible. You can say that person can awaken from sleep very quickly. Uh, as you know, like a lot of neurobiological things are involved, but still the reversibility of the sleep can be done very rapidly. And it's also neurobehavioral state, and mainly characterized by quiescence. Quiescence is again very silent, because person who's silent, I don't know how many of you are still sleeping in this class also. We don't have any this one, so quiescence will be there like this class. Also postural recumbence, because sleep always leads to on the lying, or even if on the sitting person is sleep, he loses his postural because of the restless, and also to the because of the neurotransmitters not releasing the neurotransmitters. Okay, few excitatory neurotransmitters, and also reduced awareness of the environment. Okay, so this is the very important things where we can say like sleep when usually driving, all know when sleep comes there will be a lot of accidents also can occur. So this is what reduced awareness of the environment. Okay, will not be sensed what's going on around, and also is considered as a psychiatric. Okay, it's a vital sign. You can say that anyone if we say like go for any disease for evaluation, one of the psychiatric evaluation is also they ask sleep. Okay, how the patient is sleeping, and many times you can see routinely that sleep also will talk about that. Okay, this person can sleep anywhere. Mhm. Means when sleep is there, usually as a general rule, that person is healthy or away from tension. Okay, so that's how usually we classify as sleep. It's a very vital sign, and it's also require routine evaluation and treatment. So whenever the sleep disorders are encountered, it has to be uh, carefully evaluated and treated. And as you know, like sleep is very important for proper brain function. So it is a time for giving the regeneration. Okay, it's a resting time for the brain where it can take off of thinking, replying, behavioral, psychiatric, all those things. So sleep will usually makes this circuit breakdown for some time, and again, if it is restart, usually the brain functions will be better. That's why sleep is very important. And this is what the neurobiology of the sleep and wakefulness. Okay, and this is the center one. We can see that this is awake and very alert, creative, and problem solving. So this is the state where a person becomes is very active. And if you see the part of the brain here, there are a lot of neurotransmitters which is useful for analyzing the patient's the wakefulness and this one. So one is such like histamine, HA, and another one is dopamine, DA, and the acetylcholine, 5-HT, serotonin, norepinephrine. So these are all the very important neurotransmitters in deciding the conditions of the person. Okay, so when these are all equally managed, then the person is awake, alert, creative, and problem solving. And you can see this side is any excitatory neurotransmitters reactions more, it becomes excessive arousal, and from this side to here there is a deficient arousal, more sleepiness. So here you can see that there is an hypervigilant person cannot, it's very active, and insomnia, you'll not get the sleep. Okay, and there is also a cognitive dysfunctions, you cannot think, or thought process does not happen because of the overstimulation. And also there is a panic and fear in this part, and also there is an hallucinations and psychosis which usually happens. So all this leads to the excessive arousal of a person, and this kind of persons getting to the sleep is very difficult, you will not get the sleep itself. And you can see the other part of this is the inattentive. This person means becomes more of drowsiness and less stimulation. And also there is a cognitive dysfunction, that is under stimulation. And also there is an excessive daytime sleepiness, drowsiness, and also sedation, and always you will be asleep, so deficient. So you can see this part, if it is more of inhibitory hormones more active, so then it becomes this as more predominant. If it is excitatory neurotransmitters are more, then this becomes. But both equally managed is usually person will be awake, alert, creative, and problem solvers. So in this chapter, we will handle both sleepiness and also the insomnia. So getting too much of sleep or not getting sleep. Okay, so both the aspects we will be talking about in this chapter. So this is an the spectrum of the sleep and wakefulness. So there is a lot of neurobiologically, a lot of models can explain like how the sleep will come and how we be wakeful. Okay, so as shown, like there are 5 new key neurotransmitters. The histamine. Okay, histamine is one of the very important thing for any kind of arousal. If a person has to wake up, then the histamine is very important thing. Also, the dopamine, norepinephrine, serotonin, and acetylcholine. Okay. And apart from this, there is also another neurotransmitters which equally contribute here. It's not included here. That is GABA. So GABA is an inhibitor neurotransmitter actually. So which is more helps in bringing of the sleep to the person. So when there is a good balance between too much and too little, okay, arousal. So one is awake, alert, and able to function well. So there should be always a balance in these neurotransmitters. It should not be too much or too little. So the one has to get a lot of sleep, and not oversleeping also is causes a lot of imbalance, and also not getting sleep also will cause the imbalance. So that's how we have to manage the balance everything. And there is a switch in the brain, in the hypothalamus. It's a center for controlling for sleep and wake in the brain. It's a very key control. So we can say that when this hypothalamus key is off, okay, then its setting is off, then it is a sleep promoter. Okay, so it is located within the ventrolateral preoptic nucleus, VLPO. Okay, ventrolateral preoptic nucleus. So you can just remember the abbreviation. What is that? See, don't disturb in between. Okay, so this is the VLPO, ventrolateral preoptic nucleus of the hypothalamus. Okay, you can just remember these words, the abbreviations. It will be coming repeatedly coming in the future slides. And also there is onsetting, the wake promoter. This is localized within the tuberomammillary nucleus. Okay, that is known as TMN of the hypothalamus. So this is the switch. If this is off, okay, then it is sleep promoter, and if this on, then it is a wake promoter. Okay, so these 2 key neurotransmitters will regulate the sleep and the wake switch. As I told, like in the TMN, the histamine for the wakefulness, and in the VLPO, GABA, which is an inhibitory neurotransmitters, is responsible for the sleep and the wakefulness. Any questions?
No, sir.
No, sir.
Okay. And then we see all the processes regulating the sleep. And the circadian wake drive is a main important thing, which usually the circadian rhythm we call it as. It's like the circadian is explained like a switch, a change, okay, in the full this. We can say that sleep is opposite to wakefulness. So it's like any change in this kind of things called as circadian. It's a result of input. Like one of the few uh, the factors which influence, okay, the wakefulness is like light, any light. So it's naturally we see that even if there is a lot of light, we cannot get sleep. And even in the morning, there is a light, sunlight, which usually makes everyone to awake. So light is one of the triggering factor which influence on the wakeful, right? And also we have a neurotransmitter called melatonin. This is a very important thing again in the regulating the sleep. And also any kind of activity will all leads to the, there is a center, another center called as suprachiasmatic nucleus. Okay, so this is again else in the SCN, which is also known as. So just remember this abbreviation also. In future slides it will come. And the longer one is awake, okay, without going into the sleep or awake, the homeostatic sleep drive increases, okay, and it decreases with sleep. So that's what we say that if you say any kind of the long, there will be some particular time to get sleep, okay, and if you don't go to sleep that particular point of time and misses, you can observe that there is so much other thing. Later on, if you go for sleep, also you may not get sleep. So that we personally we can see that how body is so much used to that particular. Or if you see that one person, if one day you get sleep and lie sleep for in afternoon sometime, you can see the other day it's also the same time, you'll get sleep. So that's how you can see the body, the neurotransmitters, the memory, how it usually takes that and makes the body to go to the sleep that particular point of time. So these are more of even our the regular our activity behavior, how we see that also is dependent. And we say that like as the day progress, the circadian wake drive diminishes. So as the day progresses, evening is coming, and it's a homeostatic sleep drive increases. Okay, so that's how there is a graph. I'll show you how it is there. And also until a tipping point is reached, okay, uh, and also the ventrolateral preoptic sleep promoter is triggered to release GABA in the TMN and inhibit wakefulness. So the wakefulness of the this one it is reduced. And also the sleep or wake switch is also regulated by a neurons called orexin or hypocretin. So it's in the lateral hypothalamus region. So you can see this is LAT, which stabilize wakefulness. So just remember the LAT and SCN, the suprachiasmatic nucleus, which is for the sleep, and for the wakefulness, it is LAT, that is lateral hypothalamus, which stabilize the wakefulness. And here we can see that very importantly how person get switch from sleep or wakefulness and awake. Okay, so this is what the switch is, sleep or wake switch. Okay, so if the sleep or wake switch is on, okay, and see here as I told there are two centers, TMN is a wake promoter and VLPO, that is a sleep promoter, which is usually mediated by the LAT, lateral hypothalamus, and SCN, suprachiasmatic nucleus. Okay, And here you can see this is the histamine neuron, HA neuron, and this is an GABA neuron. Okay, and this histamine also is connected to the cortex region, because the wakefulness is usually, it has to get a signal for all other the organs, cells and tissues for the wakefulness. So this is the slide which talks about the wakefulness. You can see this is the dotted line. This is off now. Okay. So when this is off and this is on, so the wake promoter, the person wakes from the sleep. So when the TMN is active and histamine is released to the cortex and the VLPO, the sleep promoter, is on, the sleep promoter is inhibited. Okay. So when the wake promoter is on, this is inhibited, sleep promoter is inhibited. So that's how these neurotransmitters will not have any issue. The histamine will take dominancy and the person will wake from the sleep. And see this slide, so opposite that, you can see the switch here, it's off. So when the wakefulness switch is off, then the sleep begins. You can see that in the ear, the histamine release, the whole cycle is being inhibited here. Okay, along with the cortex region and along with this wake promoter. And now the VLPO, that is sleep promoter, will take in drive and releases lot of GABA neurons. Okay, and this is, as you know, like inhibitory, and suprachiasmatic nucleus will be very active in this for causing the sleep promoter and inhibiting this. Okay, so this is during this stage the person will get the sleep, and it also, because the cortex is also not initiated, the all other cells, organs and tissues, okay, especially the voluntarily, they may go to the rest. Then the body understand that person is on sleep, all the metabolic requirements will be slowed down. So this is what it's available is active. The GABA is released to the TMN and sleep promoter is on. The wake promoter is inhibited. Are you all following?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Sir.
Any questions?
Sir.
Yes. Yes, sir.
Yes, sir.
Okay, so this is how the overall process regulating drive, the hemostatic, as I told, circadian wake drive, the homeostatic, where almost at the 11 p.m. the sleep drive will mainly comes down, and this one. Okay, so the sleep occurs at this stage, and this is how the typical graph is seen. And coming to the next part of the chapter, that is the stages of sleep. Okay, the stages of sleep, I think we know, like earlier learned that rapid eye movement sleep and non-rapid eye movement sleep is there. That is REM sleep and non-REM sleep. So REM sleep is especially get the dreaming, the dreams that comes during the sleep means, if you get a dream means then you have an REM sleep. Whereas other orthodox sleep will be having non-REM. And here you can see the duration of the both kind of sleeps. You find more time is spent in the non-REM than the REM. REM is very for short period. And this is the pattern, and you can see the wakefulness here, wakefulness, REM and non-REM, and different stages, stage 1, 2, 3, 4. And if you see this, the hours of sleeping or the pattern in the thing. So within 0 to 1 hour, the person can go here to the stage 4, stage 3, stage 2, stage 1. Stage 1, 2, 3, 4. It goes like this. Earlier as stage 1, 2, 3, 4. It goes like this. And you can see that before this, from 0, there is also some wakefulness. So this part talks about the wakefulness. From 0 to, you can see that person will be awake here, awake. Then it enters into the stage 1, stage 2, stage 3, and like this it goes, stage 4. And then it's almost in year 1, you can give that stage 1. Then again, the kind of the thing is oscillating, sleeps, you can see that. Then again, person for small period, he may come back to the stage 3, and also for the stage 2 and the stage 1. Okay, and once coming into the stage 1, you can see that comes into the rapid eye movement sleep. It is dreaming. Okay, so this is you can say that completely the person is not even aware of the surrounding things, and you'll go into a very different world here. Okay, and the person feels that you are really there. Okay, so that's what the stages goes around just before 2 hours of sleep begins. Then again, once from the dreaming, I think we can know that we'll come back a little bit, wakefulness will be there. Okay, we'll feel that is not real. Then we'll come back to the stage 1, 2, 3, 4. Then again, it goes back again. Okay, so it's in like a cyclical oscillating type. You can see that there is again the almost around 3 hours we get the dreaming, and for more than the duration is also for longer duration here. So because the body is almost set that neurotransmitters and this, and once if it is after this dreaming is over, you can see that come back again to the wakefulness. Because here you may not come back, you may go to the stage 1 directly, but here you can. So because when you're dreaming, at lastly some weird things can occur, then you may feel like very afraid of that, and you get up or something, so the wakefulness may come here. And after sometimes you again go to the stage 1 and stage 2, but later on, once this is happened, you may not go into the stage 3 and stage 4. Again you come back to the stage 1, again the dream. You can see that rapid eye movement, because it goes for longer time than, you can see that the increases in the duration of this. The other way, again stage 1, stage 2, we may not get wakefulness here, but the duration of dreaming can increase. And also here, and lastly you can see this, a person may not go on just to the stage 1 and come back to the dreaming for longer time here. Okay, so only in the initial period the persons can go into stage 3 and stage 4, and now here the body is so well used to the neurotransmitters of sleep disorder, sleep thing. So that's why it does not go to the 3, 4, 1, 2. You can see even year 1 again come back to the dreaming, and lastly the person may become awake. It's almost the time could be 8.5 to 9 hours here person can awake. So these are all the different stages of sleep. Okay, so a person, normal person, usually this is the initial wakefulness, and this is the center one wakefulness, and at the end one wakefulness will be there. Otherwise, the remaining part of the whole sleep should be in REM or non-REM. And there is a lot of the activities, brain activities goes during this the sleep disorders. So you can see that there are different rays. Okay, you can see the EEG type talks about 4 types of waves. One is beta, which has a lot of quite more hertz, 12 hertz. You can see the very frequently it is seen nearby, and alpha 8 to 12 hertz, and theta 4 to 8 hertz, and also delta. Okay, so delta waves is 1 to 3 hertz. So you can see that it is having a lot of more mm, um, spaces and waves, not much intensity. So these are all beta, alpha, theta, and delta rays of 4 types of waves you can see in any kind of sleep. So if his person is awake in normal life, okay, so he has very low voltage, so and high frequency beta waves. So when there is low voltage, this there is a high frequency. You can see that how frequently the frequency, the distance between the two crust and the depth. And as you can see that this is the waves are seen in the awakeness. And if the person is very drowsy, the alpha waves are prominent. So you can see the alpha waves as 8 to 12 hertz. It's again not like the beta waves where it is sharp and this one. So this is the alpha waves. This will brings near. You can see that the frequency of this one decreases. Okay, the sleep towards sleep it goes, and if the frequency increases, the wave frequency increases. See, beta has high frequency, then the person will be awake. So here the alpha waves is having less frequency than this, it goes to the drowsy. And the next stage 1 sleep, in stage 1 sleep, the theta waves are prominent. Okay, so this is, I can say, like the drowsy stage 1, stage 2, stage 3, stage 4, then REM. This is the highest the sleep, deep sleep you can say. Since the stage 1 theta waves is having again 48 hertz, less frequent than the alpha waves. And in the stage 2, there is also sleep spindles and also mixed EEG activity. You can see some kind of here, you can see that there are alpha waves. Then again here you can see that some kind of theta waves. Okay, also sleep spindles, that is a mixture of all the waves here. Then the next stage 3 and stage 4, there are also a slow wave sleep. You can see the waves itself is having less thing, and they are having progressively more delta waves. The frequency is very very low, 1 to 3 hertz. And slowly that the frequency is seen here. But you can see the drastic change in the REM sleep, rapid eye sleep. So it's almost you are like, because you can see here, it's the pattern of waves in REM is almost similar like how the person is awake. So it's a low voltage, high frequency waves. Okay, so almost thing. So here the person has a, because the dreams or all those things, you feel like when sleeping is becomes reality, you are really there and it's happening really. So that's the feel that usually one person's get about the dreaming. So that's how the waves are almost similar to the wave. Any doubts here?
No, sir.
No.
Okay.
Sir, hello.
Yes.
Sir, can you tell once again the relation of these waves to the sleep?
The waves,
Yeah.
so this is waves, as I told, like having high frequency, awake, and the lowest frequency is during the sleep. The beta waves is more than 12 hertz, so it's one of the prominent if the person is awake. And it's a low voltage, high frequency beta waves are seen. And next is the alpha waves. You can see that
Sir,
frequency is less than that.
hello, sir.
Yeah, tell me.
Sir, I was asking about this is the vibrations that our cells possess when we sleep.
Hmm.
Hello.
Yeah, tell me. What's your question?
Hello. Sir, this the vibrations that our cell possess when we sleep?
Yeah, these are the waves. Yes, the generations of the waves in the activity. So, neurological activity. See, EEG. So when you will do the EEG,
encephalogram, when any kind of brain related things are there, we do that.
yes, correctly, exactly like seizures.
Yes.
EEG, one of the prominent diagnostic tool for the seizures, where the nerves get stimulated and signal generations happens. So same way this the nerve cells, okay. So what are the waves, different kinds of waves it's captured by the EEG. So the pattern of these waves, the neurological waves, it's more of neurological.